chemoreceptor trigger zone. That's where it works, and it's been very helpful for a lot of patients with nausea and vomiting. Aprepitant is another one that we can mention. Aprepitant, you can give it orally and you can also give it by injection, but there are two different formulations. Okay. And aprepitant works by inhibiting neurokinin 1 receptors. Neurokinin 1. It works both centrally, CNS level, and also peripherally. So if you take it orally, it usually just works at the peripheral level, but if you give it by injection, it can work both at the CNS level and at the peripheral level. Okay. So that covers basically the nausea and vomiting management.
Doctor, could you please repeat what you just said? It works both central and peripheral.
Yeah, that's all.
That's it.
Okay. Now, if we look at this drug called Capivance, that is a drug that can be used to manage a common side effect that you see with Taxol. And that drug would help to manage a problem with the mouth and the GI tract and with the sides of the lips that you can see with Taxol. And MU, mucosis. So you can use Capivance to manage that mucosis that is due to Taxol administration. And of course, we know that Taxol can also produce your myelosuppression. And so for myelosuppression, you can use GCSF, that is the colony stimulating factor, granulocyte colony stimulating factor, or one can use epoetin if the red blood cells are the ones that are affected the most. Aranesp is another agent that can be used if there's bone marrow depression and it affects the red blood cells a lot also. You can use Aranesp. So the last thing we have there to cover is the increase in uric acid, hyperuricemia that you see with some anti-cancer drugs like the vinca alkaloids. Any drug that breaks down the cellular structure rapidly would usually give you hyperuricemia. You'll see it as an adverse effect of that drug. But one noted example is the whole group, the vinca alkaloids. Normally, 5-ribosyl phosphate in the presence of pyrophosphate will be converted to inosine monophosphate, and the inosine monophosphate can then go on to adenosine monophosphate, xanthine monophosphate, this is xanthine. Okay. And the xanthine monophosphate can go on to your guanosine monophosphate. Those are the levels. Now, adenosine monophosphate can come down to its adenosine, and then it can go on down to the base. So the same thing, nucleobase, nucleoside, nucleotide. Nucleobase, nucleoside, and then nucleotide. And then that can go into DNA formation. And you see the same thing with inosine monophosphate going down to hypoxanthine, and then from hypoxanthine it can be converted to xanthine. And that's the pathway that xanthine monophosphate will follow. Then get down to your guanine going to xanthine. So this is eventually where they would all end up. And the xanthine oxidase can then form uric acid, and uric acid would go into the renal system. Okay. Now, uric acid does not stay in the renal tubule 100%, so some of it will be reabsorbed, back into the bloodstream. And if the amount that is reabsorbed is more than the amount that is being excreted eventually, then uric acid level will build up. So you can have hyperuricemia. Okay. Now I put this here, oxidase going to allantoin. That reaction happens. However, uric oxidase is not active in humans. So that's why we don't see that allantoin being produced. Okay. And if the allantoin is produced, it will just be washed out in the renal system. It's very, very soluble. So if you want to manage hyperuricemia, which probably has led to gout, gouty arthritis, you have about 4 things you can do. One will be to manage pain. That's why you use colchicine. So, one, you manage the pain that is associated with the gouty arthritis. And 2, you want to decrease the amount that is reabsorbed from the GI tract. If you decrease the amount that's reabsorbed, it means that more will be going out through the urine. And for that, you can use what is called a uricosuric agent. decreasing the amount of uric acid that will be excreted. Okay. So that's how you can decrease the amount in the bloodstream. And then you can actually inhibit or decrease formation, that is metabolism, or let's say formation of uric acid. And how you would decrease formation will be to decrease or slow down metabolism, that is cut down the conversion of xanthan or hypoxanthin to xanthan and then down to uric acid. So you decrease metabolism so you can decrease production of uric acid. Okay. And then the fourth one is actually to use a substance that can make this oxidase active. If you make this uric acid oxidase active, then more of your uric acid will be converted to allantoin, and allantoin is very soluble in the renal system. So those are the four modalities that one can use. And so the agent that can convert uric acid to allantoin has been made. Okay. And it's called rasburicase. And pegloticase. Those are two substances that have been made through recombinant DNA technology to produce these two substances. So if you give rasburicase or if you give pegloticase, it would convert uric acid to allantoin, and then allantoin will be very easily excreted from the urine. So you will not have a pile-up of uric acid that will be reabsorbed into the system. So that's one way you can manage that. In terms of decreasing formation, you can use your Uloric. So if the patient is on, say, vinca alkaloids and they're building up uric acid, you can give Uloric, or you can use allopurinol. So those would tend to manage the hyperuricemia by decreasing the formation of uric acid, because they would inhibit xanthan oxidase. So to decrease reabsorption from the renal tubule, you have to use an agent that's called a uricosuric agent. That's where your sulfonylureas would belong. They can help to increase excretion. Probenecid will be another agent that one can use. Anturan has been removed from the market, so we don't need to discuss it. So those would increase excretion of uric acid. Of course, colchicine will not affect this system. Nobody knows exactly how colchicine works. There are some suggestions, but they have not been fully agreed upon. Okay. So, let me see if I could mention.
The colchicine is only used to manage the pain? Only like the first?
Yes, for in gout, for gouty arthritis, it's just for pain. Okay. There's an agent called lesinuride. Lesinuride would inhibit these two transporters. And those are organic anion transporter 4 and urase transporter. So it's like urate, because it's the acid. Urate transporter 1. So those two enzymes can be inhibited by lesinuride, and you inhibit these two enzymes, then uric acid is not being reabsorbed, so it will go out in the urine. That's how you get rid of uric acid. Okay. So, in cancer patients, that's how you can manage excessive uric acid coming from anti-cancer drugs. So, you can go on to breast cancer as an entity. All right. Okay, we have mentioned that breast cancer mainly occurs in the epithelial cells of the mammary gland, and it occurs mostly in the duct. So the most often encountered type of breast cancer is the infiltrating ductal carcinoma. So it occurs mainly within the epithelial cells. There are other types that occur elsewhere, but that is the most commonly encountered type of breast cancer. In terms of incidence, we know that it's about 1 in 8 Americans will come down with the disease, and usually you don't see it below the age of 30. If somebody has a bad gene, like this P53 that we will mention later, or like BRCA1, it's possible for you to see breast cancer at the age of somewhere between 40 and 50. So it can occur early in individuals that have that gene. BRCA1, BRCA and beyond. They don't usually put that A there. Put it like this. So you can say it's breast cancer, BRCA. BRCA1 and BRCA2. So a patient has that inherited gene, they can get breast cancer at a very early age. And we know that it is less in Africans and in Asians. So it's more in Europeans and North Americans. In terms of etiology, how to say unknown, not known. See, whichever way you look at it, breast cancer, like any other cancer, is a disease that is genetically based. By that, we mean that you have to have a change in your genome. That is, there has to be a transformation in the DNA. So it all goes back to the genes. That's why we say it is genetically based. However, what makes that gene to be transformed is what nobody knows. Why does it change? When it's changed? No one knows. However, there are some risk factors that sometimes people mistakenly call the cause of breast cancer. They're just high risk factors. One of them is familial basis of breast cancer. All of us have some genes in the body that are called proto-oncogenes. Now, of course, you see onco, which means cancer, oncology. So proto, that's in favor of oncology. So genes that are in favor of cancer development is present in all of us. But there are also some genes that are anti-oncogenes. So the proto-oncogenes can be biotransformed or can undergo metabolism or change to form, oncogenes before they can produce a tumor which when it becomes malignant would then be called a cancer. So a malignant tumor will be a cancer. So examples of those proto-oncogenes are what we sometimes refer to as GFR, growth factor receptors. Growth factor receptors. An example would be your ERB or CRB2 gene. And that SERB2 is sometimes referred to as your HER2 gene. With H being human, that is human, the E stands for epidermal growth factor. Epidermal growth factor. So HER2 means human epidermal growth factor receptor 2. Okay. So that is one of those so-called oncogenes or proto-oncogenes. And they are sometimes referred to also as the dominant genes of breast cancer. Those ones that are called dominant genes, the patient or an individual has to overexpress those genes so that you can get breast cancer. Another example would be some proteins. Let's see, I don't want to use that CD4 yet. So, just your cyclins, like cyclin D and cyclin E. Those are two prominently encountered or cyclins that are involved in the development of breast cancer. Okay. So you have a third one, and the third one would be the genes that are referred to as CMYC or CMYC. Okay. CMYC genes. And CMYC genes would also promote, that is, they are dominant, they would increase the incidence or likelihood of getting breast cancer. These three groups will do the damage when you have an overexpression of those genes. Then on the other side, see, these are the dominants. And if you look at the anti-oncogenes, these are sometimes called the suppressor genes. The suppressor genes tend to suppress the development of breast cancer. Okay. So for you to get breast cancer from the suppressor genes, it means you have to have had a mutation in that gene, or you must have had something that decreases the amount of suppressor gene that you have. If you decrease this amount of suppressor, then it means there's nothing to protect or to prevent you from getting the breast cancer. And those ones would include like your P53 genes. And P53 genes mutation is the most commonly encountered in human breast cancer development. It's the number one. If evidence of P53 is present, it means that the patient would have a poor prognosis. And it also means that the likelihood of being virulent, that is, being very deadly, would go up.
I have a question.
Yeah.
You said anti-oncogenes, isn't it? So anti-oncogene is a suppressor.
Suppressor genes.
Yeah, so if it is suppressing, how are they getting the cancer?
Huh?
If it is suppressing the oncogene, how are
That's the reason we gave earlier. That you must have a mutation or a repression of that gene. If you reduce something that is protecting you, then you're likely to get that thing. If you inhibit the inhibitor, it's like stimulation. Yeah. Okay. And then you can have the one that we mentioned earlier before, the BRCA gene. The BRCA gene is also a suppressor gene. And you have BRCA1 and BRCA2. Those are suppressor genes. The same thing with like in P53, if BRCA gene evidence is present, that suggests poor prognosis.
Excuse me, sir. So anti-oncogene and suppressor gene is exchangeable in terminal.
It's what?
And anti-oncogene and suppressor gene
Yeah,
is
they're
interchangeable.
Yes. Okay. So if somebody has the evidence of BRCA1 or BRCA2, but particularly BRCA1, yeah, they can have poor prognosis, and they are likely to have a bilateral breast disorder or breast mutation or breast cancer. So it's not likely to be just in one breast. It's likely to occur in both. And when it is transferred to an offspring, it follows Mendelian system of transfer. And,
it follows?
yes. So that basically means that if you had 4 children, 2 of them will come down with that breast cancer. You know, one would be a carrier and the other one would not even be affected. That's the Mendelian transfer format. And those female children, the female children in the family would have a very high rate a risk rate. They will stay within the 85 percentile of developing cancer sometime in their lifetime. A male that is born to that female stands a very good chance of getting cancer also. And usually it will be prostate. A male can also get breast cancer. So the chances of that male child developing breast cancer would also be increased. The female child can get breast cancer, but can also get ovarian cancer. And their chances of getting cancer of the cervix would also increase. Now, for BRCA2, that is even when the male offspring, that is the child that is a male, has the most, that is, has the highest chance of coming down with prostate cancer. So a male child of a patient that has BRCA2, transference would have a very high rate or chance of getting prostate cancer.
Dr. Moore, so we said that most cancer due to
The what?
We said that most cancer are due to the suppression of P53 and BRCA, so that's why we catch them at stage 4 or 5, because it's already virulent, it's already gone through all those stages, we never caught them due to the poor prognosis.
Those are not, they don't correlate, it's not necessary. It's not necessary.
So are these suppressor genes, or are those P53 BRCA, are they pro-oncogenes or anti-oncogenes?
They are suppressor genes, that is, they are anti-oncogenes. That's why you have to, decrease low. Okay. And then you have some estrogen involvement or estrogen receptors. Estrogens can stimulate the growth of some growth factors, and the increase in the growth of those growth factors can increase proliferation or can cause the cancer cells to grow. And that's why we always mention that you remember, you have initiators and then you have promoters. Estrogens can be promoters. So you could have had an initial DNA alteration, and then the presence of estrogens can increase or affect the growth rate of growth factors, and they can promote the conversion of that normal somatic cell to cancerous cells.
Doctor, who is the promoter over here?
The what?
The initiator is the estrogen. Who is promoting?
Estrogens. Estrogens can promote. Alcohol can promote. There are many things that can promote. Yeah. Okay. So that is one thing that can increase risk factor. Two, we can talk about environment. And I will try to put them together. Then three, we can talk about hormones. For hormones, that's what we alluded to, has to do with estrogens. Estrogens or hormones can increase your risk of breast cancer. Estrogens control the amount of the rate at which you get certain growth hormones. For instance, insulin-like growth factor. That's one. Fibroblast growth factor. Fibroblast growth factor. That can also be affected by hormones and in turn affect the growth of tumors that can become cancer. And then you can have PD, platelet-derived growth factor being increased in terms of release or amount. Epidermal growth factor. Epidermal growth factor can also be increased. And then transforming growth factor, and that can be A or B, transforming growth factor. Transforming growth factor B is a little peculiar because it normally tends to help your immune system, to fight off infections, including tumors or cancer. However, when it occurs in the breast cancer or when it is transformed in the breast cancer, it does a paradoxical thing because its volume increases while the cancer is still going up. So instead of keeping the cancer down, an increase in the production of the B type of transforming growth factor actually does the opposite of what you expect. It doesn't go down, it increases in volume. And it is believed to play a role in the long distance movement of breast cancer. So in the long run, it may even be worse for the patient. Of course, we know A does what you expect it to do. It basically increases the likelihood, the risk of the patient coming down with breast cancer. You know, so hormones can affect the risk of breast cancer by simply increasing the rate of production of your growth factors, which will then make the cancer grow more.
Just the B, not the A. Just the B.
That will do what?
Just the B is increasing the volume and the growth factor and the risk of
No, A is no.
No.
A does what you expect it to do. It transforms the growth, so it makes it grow. B, you would expect to bring it down. Yeah, but its own volume, it goes up along with the growth of the cancer. If you had early menstruation or early menarche, if you had menstruation, if you started menstruating at an early age, your chances of breast cancer will go up. If you have a late menopause, the chances of you're getting breast cancer would also go up. So it's bad if you started early, it's bad if you stop late. You guys have a class in here?
9 o'clock, yeah.
Oh, that's for me. Oh, we have to go upstairs again.
We just started. Okay.
An hour is not enough.